Welcome everybody to the second of our series for the Canadian Society for Sociology of Health. And I'm very pleased to have our colleague and one of our CSSH advisors with us to present, Jungwee Park from the Health Analytics Division at Health Canada. And Jungwee, if you'd like to go ahead and make any additional introductory comments, and then we can just proceed, that'd be great.
All right, thank you very much, Ivy. I'm pleased to present some studies I've done, and also my colleagues' study at Statistics Canada about work stress and mental health, and before and after the COVID-19 pandemic. Well, you know, this pandemic has a huge impact on our professional life and personal life, and especially its impact on mental health, you know, has been reported to be huge. So it's a kind of important thing for us academics and researchers, and just you know, ordinary citizens to think about this issue and kind of try to learn something old and new, and try to find some better way to address this very important issue. This is very important, and you know, kind of having an opportunity to help that process is very appreciated. And look at that, the first page, nice design of the poster. My picture is a little embarrassing, but that's fine. Okay, let's move on. Okay, today's presentation by the way, Ivy like hour and a half, right?
Yep.
Yeah. So you know, I'm not really in a hurry, but we're going to talk about those issues, and if you have any questions and you know thoughts, and you can jump in anytime. And also, you know, we're going to have a kind of discussion time after the presentation, but anytime if you have any questions or ideas and thoughts, then you can jump in and we can discuss at the right moment as well. But this is kind of you know, loose plan for today's presentation of mine. First, we're going to talk about the COVID-19, the pandemic itself, trying to apply our biopsychosocial account. So when we're talking about sociology of health, we tend to you know, try to use not just a biomedical model, political economy only, but we are trying to use biopsychosocial perspective. So how is it going to be possible for the case of COVID-19? So we're kind of trying to open a discussion about having a biopsychosocial account on COVID-19, thinking about some kind of social metaphor and things like that. And second part of the presentation is going to be my introduction of analyses, which have been done on mental health and work stress before COVID-19. So this is important because it gives us a important context where you know, our new observation of COVID-19 on mental health and work stress happens. So the COVID-19 doesn't really create entirely new thing, but its effect on mental health is happening in the context of sort of pre-existing conditions. So pre-existing conditions are not just for not just in terms of the medical sense. So you have a pre-existing conditions like, you know, diabetes or some heart problems, and you know respiratory conditions. Then you are in a higher risk of having a COVID-19 or having bigger impact from COVID-19. That's pre-existing conditions. But socially speaking, you're in lower class and you're in, having a frontline work type of occupation. And you are, gender minority, you are ethnic minority, things like that. That is, socially speaking, pre-existing conditions. And such existing conditions also make a big influence on the impact of COVID-19. So kind of understanding before and after COVID-19, the before part is the context and after part is like the combination of the context and new happening due to pandemic. So kind of having the both would provide us with a balanced understanding of the COVID-19. But throughout this presentation, I'd like to show some possible data sets shared with you. And I also would like to hear from you some new ideas about research. So you want to trying to understand certain aspects of COVID-19 on our social life, for example. And we may talk about a certain kind of those kind of research questions may be better answered by certain types of Stats Canada data sets or stats, or like we can get some a new idea about making a new data set available by certain kind of linkage or something. So future studies, it's going to be a discussion, it's kind of mutual discussion, sharing new ideas of research related to COVID-19, and also, if possible, like to talk about or kind of give some guidance about the potential data sources which is available, or which were available through StatsCan. So that's my plan for the today's presentation. Okay, first of all, the COVID-19, I would say this is a unusually uncertain epidemic. So look at this this little chart about the COVID-19. We have let me try the annotation here. Let's see. Okay. Okay, so we have a latent period and infectious period and incubation period and clinical disease. So that's the situation. So here, for example, we have a clinical diseases. So at that kind of the moment, at that kind from that time on, people show symptoms of the COVID-19. So that is a COVID-19 becoming a clinical disease at this point. So before that, this is the point of infection. You got infected, but you have like certain amount of time, you have an incubation period. So you don't have any symptoms, but you do have a COVID-19, but no symptoms. So that's the incubation period. The latent period is the period, maybe the part of the incubation period, but latent period is you have no contagion. You don't infect other people. That's the latent period. The problem for the COVID-19 is incubation period is long and latent period. So that means you got infected, but you don't know, even you don't know that you get infected. You can infect other people. So this time, from this and that is the most dangerous time, and that's why we need the largest scale prevention and testing, things like that, because it is really uncertain. And another kind of characteristics of COVID-19 is reproduction ratio is about 2.5, which is not that high. It's quite similar to other epidemics like SARS. But the problem is the variance of that average is very consistent. So there is no super spreader for COVID-19. In other words, anybody can be a super spreader. So in that sense, the COVID-19 is rapidly infecting a lot of people globally. That is a huge problem that we all know, but at the same time, it has a very unique characteristic about uncertainty. So that people get to be in a special fear and anxiety. And that is related to mental health issues, I believe. Okay, that's a biomedical sort of understanding of the COVID-19, but it has a huge social implication. Oh, to clear. Not just clear. All right. So another thing, kind of sociologically speaking, we can think of is so COVID-19 has a very special nature that can cause people's anxiety and stress due to its nature of uncertainty. That has a very important sociological implication, I believe. So we can think about Susan Sontag's ideas about the social metaphor of the disease. So due to a certain nature of the pandemic, our government and the citizenry, we are all stressed out, and we are in special fear and anxiety. And as a result, we have no other choice but to take very unusual, extreme measure. So that so we actually are using the military forces to do a preventative war, and government, the provincial declared a state of emergency. So unwittingly or wittingly, our society, the Canadian society, include and U.S. society, more so, we've been using or we've been under the big influence of some kind of social metaphor. It's like metaphor. It's a militaristic metaphor. So we have to fight the COVID-19, and we must defeat the COVID-19. So that's our task, our current task, our emergency situation task. So that may be effective, and we may have the choice, but at the same time, it is dangerous because warlike metaphor. When we are talking about the war, we need who's the enemy? So now the enemy is the virus. So virus is the really enemy, yes, but it's not a person. We cannot even see. So it's really hard to keep virus as our arch enemy. So that is a problem. So we tend to find some people related COVID as our enemy. So it's a kind of transformation from a kind of a disease metaphor social metaphor of the disease change from that to a social metaphor of the disease. I mean the disease metaphor of the social groups. So, for example, well, the first case of the COVID that happened in China. So Wuhan virus or China virus or even so extreme term like kung flu has been said by many people, even by political leaders. So that kind of is an indication of our influence by the social metaphor of COVID-19, and as long time ago warned about the AIDS and about cancer, it is as harmful. The metaphor is as harmful as disease itself. So we have to be very cautious about it. But we already have the kind of pricey results, increased number of hate crimes toward Asians, the Asian immigrants. I think that is related to our social metaphor of COVID-19. And to the Asian people or visible minority people or immigrant people, that has a special implication of their mental health. So we think about that. And another metaphor we can think about it is it could be a interesting. Well, interesting is not a good proper word, but it could work as a COVID can work as a natural experiment. So how people behave to this situation, and so it. The COVID-19 is not really creating a new situation, but it is it created experimental situation where we can find the people's reaction, or we can find the opportunity of learning actually who we are. So it has as a natural experiment, COVID-19 has a very significant revealing effect. So when I was thinking about this revealing effect, I thought about the Nicholas Christakis blueprint. So is a Yale professor and also MD and a sociologist, kind of the person who frustrates me. So if he can do thing. And by the way, I'm a sociologist too, so that's that's his usual introduction. So Christakis talked about kind of evolutionary conditions and our socialization effect on our ability or our characteristic of building a society. And for that, we do need some unique characteristics, and we earn those things through the long history of our evolution and learning. That's called the social suite. We don't have to talk really about the social suite, but interesting thing is the Christakis it talked about in his entire second chapter about the records of shipwreck. So the shipwreck series from 15th century to 18th century. So in such special kind of critical conditions, how did people react? Regain the social order. How to survive and to rescue things like that. So I think COVID can be a kind of shipwreck experience to our humankind. So to kind of size our evolutionary ability to all kinds of problems, that we are facing, that may help us find a solution. So it is a kind of natural experiment opportunity as well. So what I'm saying here with experiment is it's a natural experiment revealing our maybe ability and also limitations. As such lesson can be applied to our understanding of mental health and work stress, and especially in finding kind of the best type of solutions. You know, Barack Obama is always saying like the presidency doesn't change who you are. It only reveals it. That's a kind of nice saying, right? So same thing, the COVID-19, maybe it's not creating really something new, but actually it reveals what we have had, and it reveals what kind of thing we can find as a solution. Okay, so next part, analysis of mental health work and work stress before COVID-19 is kind of studies I'm going to introduce. There is nothing new under the sun. Ecclesiastes. Maybe that's an overstatement, but yes, as I already, we are talking about pre-existing conditions, which will make an important context where the effect of the COVID-19 takes place. So understanding pre-existing research is really helpful. For that, mostly, I'm going to talk about our research on work stress of the selected professional group. IB and our group did the healthy professional workforce studies is a main part of the presentation slide. I just chose a few of them. Okay, so here CSP workers, case studies professions is kind of the unique term for our research project. But generally speaking, CSP workers, these groups, doctors, dentists, nurses, professors and teachers and accountants, we have had a special interest in those groups, and we measured their work stress and mental health and compare to those groups to other groups. So that's the main the goal of the research, and it shows good examples of the work stress and mental health, which is today's presentation topic. So this first one, the first the CSP workers, there's all CSP workers, and the next group. Let me do it again here. Okay. Okay. Maybe I'm going to draw this time. Oh. Go back. Okay. Is it? Let me. Okay. So this one is the overall CSP workers, of doctors, dentists, nurses, professors, and teachers and accountants. And this is a kind of comparison group, non-professional workers. So all these the author states the difference between this specific group and non-professional group is statistically significant. So all these are statistically significant from a non-professional group. So generally speaking, it is interesting because they are professions. They are professions like high-paying jobs, for example, and socially privileged in somewhat. So when we measured their mental health, like having a psychiatric disorder or their self-perceived mental health, oh, my mental health is excellent, good, very good, things like that. When we measure those indicators, they are better. They are, these doctors, dentists, nurses, they are better than non-professional workers, not surprisingly. But when we measure the work stress, their stress is higher than professional workers. That's the thing. But we have two indicators of stress here. One is life stress, and the other is work stress. So generally speaking, they say, okay, my life is quite a bit stressful, or my life is extremely stressful. If you said that, then your then you have a high life stress. Same thing. My work life is quite a bit stressful or extremely stressful. That determines your condition of work stress. So that's the situation. But especially look at this nursing group. Nurses showing very high work stress. It's a little tricky. Okay, so next slide, generally showing the similar thing, but it is always good to make your data more interesting by adding a different dimension of the data. So kind of the good way, a kind of common way, and also good way of doing that is adding the time dimension or adding the geography dimension. So that's make your data more interesting. So in this case, okay, before we have we found high work stress among these professional groups. So that was our finding. The next question is, okay, it is a CCHS 2013-2014, Canadian Community Health Survey 2013-2014. So that's the one of the survey shows this results. So kind of my next question is it kind of one-time thing or kind of general and of all the time? So I used several cycles of CCHS. So this is a kind of 10 years findings from 2009 up to 2018. So self-perceived high work stress percent of workers, especially at this chart. On this chart, we had a focus on physicians and nurses, doctors and nurses, and same trend, meaning the higher, statistically higher work stress were found among physicians and nurses. So no difference whether you are using 2009 data, 2011 data, 2013 data, 2017-18 data, same trend. But at the same time, we can see a little kind of declining trend of work stress, especially for nursing groups, so which is a good sign. But generally speaking, general conclusion that we can draw from this chart is still today we have a significant difference in work stress between physicians and nurses and a non-professional group. So next one, another way of making your data interesting, or not just making it interesting, but making more and finding a more meaningful message is to add another dimension. And this time is we add a gender dimension. So we are showing the men and women separately. And interestingly, we find in work stress level, look at this, the professors, teachers, let me go, we have it just a minute, let me go back. Here, okay. Teachers, professors did not have significant statistical difference among non-professional workers in terms of their work stress. But when we took a look at sex-specific group for teachers and professors, we have different story. We have new story, which is if male professors, and if you are a male teacher, then your work stress is lower than other workers, non-professional workers. But if you are female professors or teachers, your work stress is higher. So it is quite in findings, and when we kind of mix together the gender groups, we're never going to find it. So sometimes having a gender-specific data is very important. And this one is okay. Before, so far, we used under here data sources CSSH 14. This is annual data, and usually CSSH annual data measures general health status. And the next one, CSSH, we had this focused survey on health. So we had so far 2002 and 2012, we had a mental health focused health survey. So that's the unique one, and it's very the meaningful data source. If you are interested in mental health, so for 2002 and for 2012, and I'm hearing some possibility of another cycle on mental health. So CSSH 2012 is a especially focused survey on mental health. So it has information gathered on specific indicators of, for example, work stress components of skill discretion, decision latitude, kind of the job control conditions, your jobs, psychological demands, and job strain, and what kind of support you are getting from your management or from your colleagues. So workplace, one aspect of the work stress, and how secure your job is. So job insecurity, that's another component of stress. So anyway, any dimension of this whole dimension is this: the bigger the score, the worse the work stress. So bigger the score, the worse. That's the situation. So and we show male case study professors, male professions, and male non-professions and female non-professions in this case. And let us focus on this red color, female case study, including mostly the majority of our group is nurses. If we take a look at these red lines, in terms of physical exertion, how much physical force is required for doing your task, the female score is higher than male score. The female case study professions score is right here, and males here. So even in terms of exertion, the work stress was higher among women profession compared to male profession. And psychological demands, female profession is highest. Their physical demands, work stress due to psychological demands is higher than male professions, higher than male non-professional workers, and also higher than female non-professional workers. So this type of diagram, I showed each component's work stress conditions for four different groups. And what is standing out to me is the high levels of work stress in terms of physical exertion and psychological demands for female case actions. And this one is kind of the further results of work stress. So maybe work stress, the level of work stress can impact on kind of how we are doing our work. So one indicator of that is work absence. So work absence. So we compare case study professions and non-professional workers. At the same time, we also compare different sex groups within case study professions and within non-professional workers. So maybe because of the better labor conditions, maybe because of the job quality, the people who are working for the case study professions, their percentage, their rate of absence is higher. It's blue line, it's a blue triangle is bigger than the red one. Their level of rate of maybe the probability of being work absence, having a work absence is higher. But another important results of this one is compared to women and men within the professional workers, the women's level of having work absence is significantly higher. So that is a result of checking work absence. By the way, we are using 2013-14 data, CSSH, but we don't have a specific profession. We just do it as one group, one big group of CSP workers. Why? Sample size is problematic, maybe. So let me see the next slide. Next is it's kind of a similar thing. I'm still talking about work absence, but I'm showing the result of accountants, result of nurses, physicians, dentists, midwives. Midwives category is questionable, but professors and teachers, we have a specific occupational groups work absence. How is it possible? Why didn't I do it before with the triangle? Because this time I'm using Census. So Census has Census is a kind of a data set, I would say, in terms of population information. So with census, by the way, 2016 is the most recent census that we have. I can calculate the work absence level for each and every specific occupation group. So there's more detailed information, but the kind of general finding is consistent. We have higher levels of absence rate among our professional workers compared to other workers. That's one thing. And also, a huge gender differences in terms of work absence situation. Right? And maybe lastly, okay, so this is about job satisfaction. You may be interested in knowing which job is the most satisfying. Well, actually, it depends on the individual preference, I would believe. But generally speaking, the CSP workers, the professional workers like doctors, dentists, nurses, professors, overall job satisfaction rate is higher than, not surprisingly again, non-professional workers. And professors, male and female, job satisfaction is higher than other workers as well. So overall, in terms of job satisfaction, teaching maybe is a quite satisfying work. And another kind of example that that the findings we can get from the census. Census usually doesn't give us a lot of health information. That's the kind of limitation of census. So we can get economic information, and we can get the education information, mobility, and many things. It's like really indeed kind of treasure box of the demographic information, but not a lot about health. That's a census. But we do have some information about health in census. One of them is activity limitation. So to your eye problem or your hearing problem, your all kinds of problems, if you have some kind of a disability, limitation, then you can say yes to those questions. So they are the part of activity limitation questions which I included in a census. So as an example, I'm just showing information of activity limitation due to emotional, psychological, or mental conditions, which was measured in 2016, the census. And it shows, again, our group, professional men, CSP women, and non-CSP men, non-CSP women. And again here, we can see for each group, we have higher activity limitation due to emotional, psychological, and mental health conditions among women professionals. But overall, compared to non-professional groups, their rate was lower. So kind of the general same consistent trend of findings about, I think that's the kind of pre-existing findings. So we can move on to some examples of mental health related analytical findings after COVID-19. So we did have some interesting measurement of mental health issues after COVID-19, which may be impacted by the pandemic itself. Maybe the pandemic enhanced the pre-existing conditions of mental health in many senses. So that's the this is the opportunity we can measure, or trying to measure the impact of COVID-19 on mental health and work stress. But I have to emphasize, as I did it before, COVID-19 may not create something entirely new, but maybe COVID-19 help us see something that was always existing, but somehow we didn't see it clearly. So that kind of revealing effect provides a very important analytical opportunity by COVID-19 to us. So coronavirus does discriminate because that's what humans do. So that's a Rebecca Solnit's quotation. I believe that's a Guardian article or something like that. So that's right. In theory, pandemic does not discriminate, but its effect is really discriminatory. So we have a high fatal rates among old people. So age is a big factor in terms of the fatality, and also not just age, but in terms of economic impact. Some people lose jobs just next day of the COVID-19. Some people can still work, like myself, remotely. So that's that kind of occupational differences, kind of results of discriminatory application of coronavirus, maybe. And also, if you are essential workers, you are front line work, and you have no choice, of working remotely, and you are in a higher risk to get infected. So that's another. The racialized groups are showing consistently higher rates of infection and high level of economic impact, things like that. And at the same time, as I mentioned earlier, kind of expression of racism, for example, anti-Asian sentiment is occurring as well. So coronavirus as a virus may not discriminate, but its impact is all in every way. It does discriminate, and that I have no choice but to agree with Ms. Sonnet. So my second part of the presentation, COVID-19 mental health, is going to have a focus on vulnerable population groups. So I'm going to talk about different and also different race and immigrant group and indigenous group, things like that. So I have to say the COVID does make a very strong impact on our work at Canada as well. First of all, there was a huge demand for the new information about COVID-19. So it's not census. Census happens every 5 years, and we prepare like a couple of years, and about the findings, we prepare again another 2 years, and we give the findings of 2016 actually in 2018. So that's the kind of time lag that we usually make, but we have no kind of privilege like that for COVID-19. It's a huge demand. We have to provide to a Canadian public as fast as possible about new information of COVID-19. That's one big demand. And the second demand about COVID-19 is it's like, as I mentioned earlier, Chris Takis' book, the human beings we have a one of the social suite is ability of social learning and teaching. So we've learned that from many examples of COVID-19 indeed discriminates toward different racial groups. So all of a sudden, there has been huge demand for the data based upon social groups and the social minority groups. So we had to respond to that very important data demand that happened due to COVID-19 emergence. So reaction to that, kind of the typical, kind of the representative answer to that data demand is web panel survey, new survey, and it's a rapid survey, and crowdsourcing survey. So the web panel is administered to a subsample of labor force survey respondents, approximately 7,200 people. Not a huge sample, but it's kind of quick survey, and it's a very specific survey about COVID-19 and its impact. And it is probability sampling. So web panel, even though the sample size is not huge, that sample is representative of the Canadian population. So that's one part of the answer. The second part of the answer is a crowdsourcing survey. StatsCan never did it before, but this is kind of the new attempt because we are in a very special situation. So for the crowdsourcing survey, any Canadians, all Canadians are invited to participate in this survey. And we opened the survey. Okay, so StatsCan is collecting information about the COVID. Anyone can come and answer our web survey or our crowdsourcing survey. You know how many people really answered? 240,000 participants. It is really amazing. We always, StatsCan, we always are worried about these days, low response rate. We just give freedom to all the people, and we get 240,000 participants. This is amazing. So we get the information, but again, we welcome everyone. That means this sample, 240,000. Well, that's the first cycle. Next cycle is much smaller than that. Okay. It's not probabilistic sample, so non-probabilistic sample. In other words, it is a convenience sampling. So it doesn't really represent the Canadian population. It is a good source of information, but you cannot say, well, based upon the crowd survey, okay, the female participants, mental health, the poor mental health rate is 10% higher than male participants. But you cannot, if you had that findings from that survey, you cannot really say, oh, Canadian women is 10 percent point higher in terms of mental health situation, poor mental health situation. You cannot really say that because it's sample representative. You have to say like participants, the female participants in so-and-so crowding source survey showed 10% point higher in poor mental health compared to male participants. That's the right way to say it. The sample is not population representative. So that's a huge difference. But anyway, both are very important sources of information about the COVID-19. Okay, so example of the findings. This is studies, and it shows okay, so very specific. Based upon a labor force survey, we calculated average time work hours of nurses. Okay, so certain portions of nurses, actually quite a bit, portion of nurses are working overtime during this COVID-19 month. And how about their average overtime hours week? So that's the number, and it shows statistically significant increase in number of overtime hours in April and in May compared to April last year, compared to May last. So we compare overtime work hours 2 years, same month, 2019 and 2020. So more specific one shows this. So I added, I said kind of way to make the social data more interesting and more meaningful is to add a different dimension like time or geography. So this is a case of adding a geography in presentation of social data. So it shows the Canada, Quebec, Ontario, and rest of Canada. So Quebec and Ontario, the two provinces, the hardest hit by the COVID-19 during these 3 months, March, April, and May. And it clearly shows a huge jump from compared to same month, same province last year, huge jump in overtime hours, average overtime hours for overtime working nurses. That's the finding. Look at this one. Okay, so we know nurses are overtime a lot, and they are the very important part of healthcare frontline workers, right? So we are really appreciative of their service. But for Quebec case, average Quebec case, let's say in May, overtime hours is almost 17 hours a week. 17 hours a week overtime. That's a lot. So it's kind of indirectly shows what kind of job demands, that the nurses in Quebec had to receive at that time, at the peak time of COVID-19. And earlier, we had the data about job demands, psychological demands, and we found that psychological demands of the job for nurses is the highest. So, but the condition, because of the COVID-19, definitely get more serious, get more challenging, for sure. Okay, next one is now we are getting into a more specific type of vulnerable population. And this is immigrant group, immigrant status, and a level of anxiety. So level of anxiety of participants by immigrants and period of immigration. So it shows a level of anxiety of participants by immigrants status. It is based on not on web panel survey. I introduced two different type of surveys. This is a result of crowdsourcing survey. So that's why I use participants here. So based upon crowdsourcing survey, we have this. We have a kind of a different the percentage of a level of anxiety. We have no symptoms and minimal symptom and mild symptoms and moderate symptoms and severe symptoms. Moderate symptoms and severe symptoms. So highest group is always recent immigrants. So immigrants came to Canada within past 5 years. They are the highest impacted group. And the second is non-immigrant, Canadian-born. And maybe most resilient group is you are immigrant, but 6+ years since your arrival. So important thing over here is when we are talking about immigrant health and immigrant mental health, you cannot really have just one group because immigrant people have a high level of diversity. So at least we have here two levels, recent and established, up to 5 years and 6+ years since arrival. And when we have groups, they show entirely different results. So when we are talking about, when we are examining the mental health or general of immigrant group, we need some levels of specificity that's important, and that applies to level of anxiety during the days of COVID-19. And next one is this is the population group based upon race and ethnicity. So proportion is not exactly health data, but mental health data showing the similar trend. The proportion of participants who reported that COVID-19 has had a moderate severe impact on their ability to meet their financial obligations or essential needs by specific population groups designated as visible minorities. So we have usually we have about 12 visible minority groups in the census. But we are showing only here 5 visible minority groups, white groups. So we have South Asian, Chinese, Black, Filipino, and Arab Canadians. And as we can see, the visible minority groups included in this chart showing higher levels of reporting financial difficulties due to COVID-19. And I did not include every chart here, but same study shows mental health as well. But interestingly, South Asian group in this chart show the highest level of reporting financial difficulty, but they are the group who report again the highest level of self-perceived poor mental health. So we can see kind of close relationship, the perception of their financial insecurity and the perception of their mental health situation. And this is a proportion of participants who are very and extremely concerned about the potential impacts of COVID-19. So we are concerned about impacts of COVID-19 in many senses. The COVID-19 worries me because I'm worried about my own health. That worries me is how household members' health is concerned because of COVID-19. And how about other vulnerable people's health? How the COVID-19's impact on entire Canadian population's health? And how about world population's health? And how about the impact on healthcare system? The COVID-19 may overload our healthcare system. And how about the possibility that COVID-19 cause disorder? And how about the problem of maintaining social ties? People get more alienated from each other. And how about impact on the ability to cooperate and support each other as a social integration issue? And how about the ability to cooperate and support one another after crisis? Can we really go back to same normalcy? Can we go back the real same Canadian society like that? That's kind of the concerns that people have. And how about the family stress from the lockdown situation? So we have report of the increased family violence during the social distancing lockdown period, right? So, but all these important indicators measured and compared by gender status. But the kind of the new thing here is we have more than male and female. We have male group and we have female group and we have gender diverse group. The question itself asks, what is your gender? Male, female, other? Please specify. So you have the three options. So this gender but diverse group includes cisgender, includes transgender group, and anyone who did not answer their gender question excludes as male or female. So that's the way. And we show this gender diverse group is the highest concern groups. They have biggest worries about all these issues coming from COVID-19. And next one is indigenous group, how our indigenous population, the COVID impact on them. And it shows the comparison between in terms of mental health in indigenous and non-indigenous participants. So it shows self-perceived mental health, reported fair or self-rated mental health, as opposed to very good, excellent, or good self-rated mental health. So in terms of percentage of self-rated, kind of negative self-rated mental health, indigenous group is higher than non-indigenous, and also the impact of COVID-19. So after COVID-19, my mental health get worsened. That percentage is higher among indigenous group as well. And in terms of life stress, most days in my life, these days after COVID, as quite a bit stressful or extremely stressful. That is also higher among indigenous group, and reported symptoms consistent with moderate severe anxiety. The general symptoms we measured for other groups as well. That again, the rates are higher among indigenous groups. So, but this health inequity has been reported for years. Unfortunately, but the COVID situation doesn't change anything, and health inequity between indigenous and non-indigenous groups still exists, and it shows the same trend very clearly. And next one is, okay, so up to here, all the results about COVID-19, that's the crowdsourcing survey. So that's why we saying a participants, so and so percentage of participant did report high stress, things like that. But this one, my colleague, this one is about the panel study. The sample size is small, but panel study is population-based survey. So we can say the title, look at the title, Canadians, not the participant. Canadians with fair or poor self-perceived mental health, they are more likely to report increased use of cannabis, alcohol, and tobacco products. So this is a kind of life change under the impact of COVID-19. Anyone agrees your life has been changed after the COVID-19. Maybe you watch more movies, maybe, and and drink more. That's my case. Drink more, and the less exercise, things like that. So, but it makes a kind of unfortunate vicious cycle, right? So you already have a fair or poor self-perceived mental health, but those individuals are more likely to involve in poor health behavior. So you have you have poor health, and also you are doing you are reporting increased use of alcohol, tobacco products, and cannabis products. So that is a kind of interaction between mental health and health behavior, and as a result of that interaction, mental health would be again negatively affected. So next one is another colleague of mine did this interesting stuff, again based upon the web panel survey. It's about health behavior, but there's a positive ones. Most Canadians participate in activities to manage their physical and mental health during COVID-19 pandemic. So we are overall, most Canadians, we are doing positive coping as well. How? The 90+% of Canadian people report we do communicate with family and friends. We do Zoom a lot, maybe. So we maybe a family conversation is more often these days. And that's the next one is exercise outdoors, and exercise indoors, and changing food choices. That's a good one. So maybe we more concerned about our diets. And last one, yet still more than 25%, more than a quarter of the Canadian people do meditate. This is very interesting. So meditation helps our health and mental health for sure. I'm not sure I have done it, but so lots of people, more quarter of Canadian people are reported, they are doing meditation during this difficult COVID-19 pandemic period. So these are the kind of examples of the StatScan data-based analyses about mental health and work stress. So you may get some ideas of what can we do further, or what's missing, or what you really like to do about, measuring and understanding mental health and work stress, especially with a focus of the impact of COVID-19 pandemic. So we have done a lot, and if you go to this link, then you can show all the all the new analysis, all the statistical analyses after COVID-19 done by analysts of Statistics Canada. So just remember this. I'm going to make a copy of this this link, and also it's being updated regularly every week. If you go there, you can find many interesting analyses, and you can find something that may be of special interest to you. Important link. And what we are doing, myself and with Ivy and the research project team of Healthy Profession, we've been trying to kind of including longitudinal studies of mental health and work stress conditions of workers and case studies of professions and things like that. So longitudinal studies, not like CSSH, like one-time surveys, or it can really help us finding out the real causality. So by having a different time point, we can really talk about what causes what, right? So, for example, by using a linked data set, we can have based upon census, we have a different individuals working for different professions, and then we have hospitalization data, or tax data, or mortality data, which is the vital stats or administrative data sets. So we link those two, then we can find, okay, we have a certain number of professional groups based upon 2006 census. And then we follow those same individuals for the next, 15 years. What happens to their mental health status, to their survival, and to their work experiences based upon tax information. So that's a kind of new way of doing the analysis. It's in terms of doing it and going, having a process of getting the data and analyzing data. It's really somewhat challenging, but it is really worthwhile, and that's the kind of the goal that we have had, how to effectively use longitudinal data set for our research project, and to obtain the better understanding of mental health of the Canadian people. And also, the new surveys are being prepared. So as I said, the panel survey and crowdsourcing survey, they have a special component of mental health. And also, as I said earlier, CSSH, Canadian Community Health Survey, like 2012, we may be having another special cycle of CSSH on mental health. So that's a kind of possibility. And also, I was informed that Statistics Canada and the FAC, Public Health Agency of Canada, they are planning a new and special survey of health. So we're going to have thanks to COVID-19 situation, we're going to have many new and exciting sources of data on mental health. And we're going to get a good opportunity to understand better the mental health and work stress of the Canadian people this time, and this before and after, and before and during and after the COVID-19. So we're going to learn many things from those new opportunities.
That's great. That's wonderful, Jungwee. And thank you so much for sharing these. And I'm especially happy to see that there will be some continuation in some of these surveys and that we can look at changes over time. There are some comments that I've made in the chat and questions that I've posed, but I want to just open it up to anybody else who has come in to participate, and feel free to ask a question. You can just unmute yourself, and yeah, we'd be happy to take questions.
It's Nicole. I have one question.
Okay.
This is really interesting. I've seen the early stuff that you presented before, but the COVID stuff's very interesting. Did any of the surveys or panels, did they ask questions about housing? I'm just wondering because one of the unique things about COVID is that it requires us to sort of shelter in place. And I'm wondering if some of the findings that you have can be explained in part by, like, I'm thinking about the gender diverse group. So some of the anecdotal things that I've been hearing is that if transgender young people have to shelter in place, they have to go home, and if home is not a particularly welcoming place, then that may account for some of the things that you found. So yeah, I'm wondering if you've asked about housing, or if you can ask about housing in your work.
Yeah, that's Nicole. That's a very important question. I cannot really say, I cannot really remember something is done it already or not. It's highly likely. So the link I introduced, that's the kind of the place where we can check. But that's a very important point. Housing condition that makes a huge difference in terms of the impact of COVID-19. When we were doing the nurse the overtime work at the early stage, we talked about it actually because Census we do have a number of people living in the same household, things like that. So by using that variable, we can check how different the people are affected living in a different type of housing. So it's like the crowdedness of the housing, it's a big impact, and it's a kind of the real impact on the infection as well, right? So you are more people in the same kind of the housing unit, then you get a higher chance to get infected. And also that housing condition factor is overlapped with the neighborhood and your jobs and your social class and social conditions. So that's very important. I think it's something related has been done, but I really like to check, and it's really worth us doing more on that matter. Another thing about housing, well, this is kind of the general the principle, or kind of the trick that when we have we don't have information for specific groups, then we use geography. So like when we don't know the impact of the racial minority on something, then we calculate using the census geography. We kind of make groups of the highly diverse geography, highly diverse neighborhood, and middle diverse neighborhood, and then a least diverse neighborhood. So, and then we compare the COVID-19 infection by such geographic characteristics, and we do find the important findings as well. So I don't know.
So yeah, there are interesting
Are
proxy
there
measures that you can use for housing, but yeah, it's a really important point, Nicole. Thank you for raising that. So we have about 4 minutes left, but we still have some time for some questions. If you would like to ask, please go ahead.
So Ivy said you said you wrote something as in a chat box, or
Yes, so there are, I do have some questions in the chat box because, and some of it was just, you know, related to, was a mental health survey was that planned already for the CCHS? Like, do they plan on doing something every 10 years? Or is this something, you know, that's COVID related? So that was one question that I had. So I'm curious about that.
yeah. So you know, if nothing happened, then it's CCHS mental health. It's like a 10-year term. So it's the turn of the CCHS mental health. But then we have a COVID-19 happen. So all the regular things has been delayed or canceled. So I do not have a definitive answer of a CCHS mental health focus.
Okay.
Because
I would have expected that they would have accelerated it, you know, given the context. Yeah.
Yeah, that's right. That's right. So the question is whether it's going to happen. My answer is likely. When is it going to happen? Big question, because as you said, now it's not going to be the same mental health survey because of this COVID. It's going to include more COVID related. So it's kind of more complex design, I guess. So
Yeah.
it may happen a little later than usual schedule.
That sounds very familiar to.
Around, but I don't.
It sounds very familiar to our survey that we had to kind of wait and pull back. And for those of you who are not, you know, part of our team, we're going to be going out with a survey, but we were supposed to do it back in March before that came out. So these crowdsourcing surveys and the panel surveys, there are going to be different waves of them with a different focus, or is there some type of longitudinal component to them?
Well, it's somewhat longitudinal, but it's not exactly longitudinal because well, it's more like a trend analysis because it's not exactly the same people for a long time. So, but it's like we have so we have a May 2020, we have this kind of findings and kind of the similar group, but July we have this. So as COVID evolves, people's reaction to it has changed.
Okay, so there was one in May, there was one in July, and is there one in the field right now?
Yeah, we have cycles. Yeah.
Okay.
We have many cycles.
Yeah.
So I believe the crowdsourcing has more cycles, maybe because of the convenience of conducting it. But we do have the panel survey as well. We do have different cycles, and the newer cycle and is already lined up. So it's going to happen. We're going to get more data, and we can see kind of trend over the month and over the year. In that sense, it is longitudinal, but it's not exactly like you know, following the same individual type of longitudinal.
Yeah, no, excellent. All right, well, I see that it's 2:30 and I should do my job as a moderator just to close off. So thank you so much, Jungwee. Really, really fascinating stuff happening at StatsCan, and so much that we can draw upon, you know, to build, programs and policies and services, as well as just, medical sociology more broadly. So thank you so much. And I'll stop pausing. If anybody would like to ask questions afterwards,
right.
we're happy to stay.
That's right. So my last slides is my contact information, so people can use it.
That's super. Thank you so much.